Migraines in a woman's life. The term menstrual migraine can be found in many texts on the subject of headache. It seems so natural that hardly anyone has questioned it for many years. Research has shown, however, that this connection, which is taken for granted, between hormones, menstruation, pregnancy, menopause, birth control pills and migraines has to be put into perspective. Menstruation and migraines. If you want to define the temporal relationship between menstruation and migraines, it makes sense to set the period to the time of the menstrual period itself, as well as 3 days before and after. If this criterion is set, the statistics show that a maximum of 1 in 20 women with migraine belongs to this group. In other words, the term menstrual migraine only applies to a small proportion of the affected patients. We know from clinical and experimental studies that the triggering factor can be found in a decrease in the level of estrogen. The absolute hormone level, whether it is high or low, does not seem to play a role, just the sudden drop. Further, analyses of the hormone concentrations have so far not produced a uniform picture. Neither the values of the follicle-stimulating hormone, FSH, nor the luteinizing hormone, LH, differ in patients with menstrual-related migraines from those in healthy control groups. Pregnancy and migraines. The migraine is of particular importance for a possible or existing pregnancy. On the one hand, the question arises of how a migraine should be treated during pregnancy, in particular which drugs are indicated or contraindicated. On the other hand, affected patients worry whether the pregnancy is threatened by the migraine disease. Finally, what is important is the impact pregnancy can have on the course of a migraine attack. Pregnancy relieves migraines for most women. Pregnancy is a carefree and pain-free time. It is known from studies that in almost 70% of the affected patients a significant improvement or even a complete absence of migraines can be observed during pregnancy. This effect is particularly evident in the last 2/3 of pregnancy. It is still unclear whether the positive effect on migraines gradually wears off with repeated pregnancies. After giving birth, almost half of the patients complain of a recurrence of headaches in the first week, mainly tension-type headaches, but also migraines. The cause of the sometimes spectacular improvement in migraines during pregnancy is still completely open. However, various hypotheses are discussed. Initially, it is believed that the increased levels of estrogen and progesterone and their constant levels during pregnancy are the basis for improvement. Other explanations assume that an altered serotonin metabolism during pregnancy and an increased concentration of endogenous opioids, endorphins, are responsible for the improvement. However, the changed way of life during pregnancy seems to be of decisive importance. Pregnant women tend to be more conscious about their diet, have a regular sleep-wake cycle, avoid alcohol and nicotine, try to live more stress-free and are less stressed in the work process. Treatment during pregnancy. In general, drug therapy should be avoided during pregnancy, if at all possible. This is particularly true of course for prophylactic measures that require medication to be taken on a daily basis. These drugs, beta blockers, flunarizine and the serotonin antagonists, must not be taken during pregnancy. This is especially important if pregnancy is planned or even possible. Since young women in particular use such drugs for severe migraines, the doctor must point out the need for safe contraception. To prevent migraine attacks, we recommend, as usual, primarily behavioral measures such as relaxation exercises and avoiding the triggering factors. Drug prophylaxis? In the case of extremely severe migraines during pregnancy, especially migraines with aura, magnesium should be tried as a prevention. The effect of magnesium on the course of migraines was generally rather small in clinical studies, but in individual cases it was extremely impressive. For the treatment of arterial high blood pressure during pregnancy, the doctor generally prescribes propranolol, a product that is also used successfully for migraine prophylaxis. There were no teratogenic effects. Nevertheless, propranolol should only be used very cautiously during pregnancy for migraine prophylaxis and should only be considered as a last resort. The acute therapy. There is very little literature on the efficacy and tolerability of drugs in the treatment of migraine attacks during pregnancy, childbirth and breastfeeding. Paracetamol was previously considered the safest pain reliever during pregnancy. Based on the earlier data, there seemed to be no doubt about the security. Pregnant women were advised to take this pain reliever for pain during pregnancy with almost no hesitation. Based on current studies, however, a careful rethinking of this recommendation is required. The ingestion of paracetamol by the pregnant woman and contact of the unborn child with the drug later appears to lead to a significantly increased risk of developing asthma and respiratory diseases as well as possible infertility in boys and children. In recent years there has been a significant increase in the incidence of asthma worldwide. Paracetamol is the most commonly used pain reliever. At the same time, the incidence of asthma in the population has increased significantly in recent years. Paracetamol can reduce glutathione in the lungs. It is believed that glutathione plays an important role in the development of asthma. Birth control pill as a trigger? In the case of stubborn and difficult-to-treat migraine attacks, the birth control pill is often identified as the culprit. However, if we have a closer look at the facts, no clear connection is found in waterproof, double-blind and placebo-controlled studies. The recurrence of migraine attacks in connection with the use of the birth control pill is also discussed again and again. Since migraines occur particularly frequently in the second decade of life, for example exactly at the time when the contraceptive pill is usually taken for the first time, there is at least a statistical relationship. It is currently unclear whether this is a causal connection. New studies have shown that the risk of stroke in migraines is increased by a factor of 2 to 3. Since the birth control pill additionally increases this risk, especially in connection with smoking, a neurological examination should be carried out as soon as possible if neurological disorders occur suddenly, dizziness, paralysis, speech disorders, etc. This also applies if unexpected headache attacks occur, which can also occur on a daily basis. Menopause and migraines. It is often the opinion that migraines gradually burn out in old age. That is, they decrease in frequency and intensity. Studies show, however, that more than 50% of those affected have not seen any changes in their previous migraines during and after the menopause. In about 47% of the patients there is even a deterioration. Even today, some patients with severe migraine attacks are expected to have the uterus or ovaries removed for migraine prophylaxis. However, it has been proven that this has no influence on the course of a migraine. Even hormone therapies in old age cannot influence migraines. Accordingly, in this situation too, migraine therapy should be carried out as usual.